Hello and welcome to the Clinical Care Options podcast on hot topics in NASH. I'm your host, Zachary Schwartz. This series features experts in endocrinology and in hepatology covering the latest in screening, diagnostic tests, evidence for diets, and treatment, and each one is followed by an in-depth question and answer session. Today's episode is entitled Emerging NASH Treatments. During this episode, Professor Philip Newsome from University of Birmingham in the UK will review the agents in late-phase clinical trials for NASH. For more information on Professor Newsome and for a link to additional online education on NASH from Clinical Care Options, please visit the show notes for this episode. You can also go to the show notes to see the slides that accompany this podcast. So let's get started and hear about the evidence behind emerging NASH treatments from Professor Newsome.
Good evening from the UK. So what I'd like to do in this session is walk you through the current therapeutic approaches for NASH with a focus on pharmacotherapies, and then really touch on the very many new treatments which are coming through phase 2 and phase 3. And then finally, a kind of reflection as to how we might use or how we might best target therapies in the future. So if we go back to the first trials really that kicked off the field properly almost 10 years ago now with Aramchol and the NASH CRN. So this built on previous evidence and looked at testing pioglitazone, PPAR gamma agent, and vitamin E in patients with NASH. It was the first trial of its type, and it was a biopsy study. As you can see, it was a placebo-controlled randomized trial with 3 arms. Now, one of the things you'll see is that the field has evolved. So when this trial first started, the primary endpoint was a reduction in elements of the NAFLD activity score, which is a histological way of evaluating inflammation and hepatocyte ballooning. And you add these up. So what they were looking at was a reduction in the score, of which ballooning is one of the key elements. So what you can see here when they analyzed this study after 2 years worth of treatment is that the p-value had to be 0.025 because it was split across the 2 arms. So vitamin E was significant. However, pioglitazone narrowly missed out on significance. Now that's been discussed at length since then. And one of the feelings is that was probably a reflection of a higher number of patients in the pioglitazone arm, bizarrely not having NASH at baseline. So it reduced the numbers of patients in that arm and therefore reduced the power. If you then look at the other histological elements, you see a fairly clear trend. So you'll see reductions in fat, you see reductions in lobular inflammation, and you can also see reductions in hepatocellular ballooning. Now, the field's moved on, and as you can see in this slide here on the right, we now look at resolution of NASH as really the kind of gold standard way of assessing the impact of an agent on liver injury in the setting of fatty liver disease. Now, what you'll notice, though, is that this graph or the bar chart on the right is almost the opposite finding of the one on the left. So what you see is that actually resolution of NASH, so not this composite score reduction, but the business of you no longer have NASH, was actually significant for pioglitazone, but not significant for vitamin E. So one of the challenges in the field is histology and how you interpret it. Since then, there's been some very nice work by Ken Kusi and colleagues who've looked at pioglitazone. There have been many other studies, but this is a really nice one. Specifically here, looking at patients who've got NASH and diabetes, whereas before, the focus really was on NASH patients without diabetes. And what you see here in this study, which again is very similar of many of the subsequent studies, is a really compelling effect of pioglitazone. So you'll see here, in this situation, the endpoint was looking at a liver biopsy and was looking to see if there was a 2-point reduction in the NAFLD activity score with no worsening in liver fibrosis. And what you can see here is almost 60% of patients achieved that versus just under 10% in the placebo arm. And again, if you look at resolution of NASH, which is becoming a more and more important endpoint, you see just over half of those patients receiving pioglitazone had resolution of NASH, and also not powered to look at liver fibrosis, but again, a trend or a suggestion that you got a greater likelihood of having an improvement in fibrosis with pioglitazone. So that's the data on pioglitazone, and there have been systematic reviews and meta-analyses which really suggests that pioglitazone histologically is effective at really reducing all the domains of liver injury in the setting of fatty liver disease. So what about vitamin E? Well, I think that Piven's observation perhaps surprised people, and consequently, vitamin E has been used, I think, more so in the US than, say, Europe, But what we haven't had are data that talk to the longer term consequences of using vitamin E. So sure, histology may get better, but what happens to the patient? And that's increasingly relevant because we, as we'll touch on later on, the way that new drugs are going to be approved is by demonstrating that they have an effect on hard endpoints like survival. So here's some nice data published from a group in hepatology last year. This was not a randomized controlled trial, but it was a large study, so just under 250 patients who were followed up for just over 5 years, looking to understand, what is the clinical course of patients receiving vitamin E. Now, of course, in these kind of studies, you can try and adjust for confounding factors, and they did this very well, but it's not quite the same as a randomized controlled trial. So these are patients in whom the clinician has decided to give them vitamin E versus not. And what you see here is that transplant-free survival was significantly improved in patients receiving vitamin E. You see that on the left. And on the right, you see the proportion developing hepatic decompensation was much lower in those patients receiving vitamin E. So, really giving some additional emphasis or support for the notion that vitamin E could be having an important beneficial effect. Now, the mechanism of vitamin E, well, historically it's around modulating oxidative stress. You see the reduction in non-alcohol in the NAFLD activity score, but notably not the impact on resolution of NASH. So it's sometimes quite difficult to really pin down what the mechanism of action might be of a specific agent. If we come to the PPARs again, there's very good rodent data suggesting that it improves insulin sensitivity, which may be one of the key finders. But it's still sometimes difficult to unpick. So one of the observations around vitamin E and pioglitazone are about their other effects, and this has probably caused the field to sometimes be uncertain as to whether to use these agents or not. So, for example, with vitamin E, there have been studies demonstrating that all-cause mortality is actually increased, albeit modestly, at the dose of 800 international units a day. There's some conflicting data as regards hemorrhagic and ischemic strokes, and also an increased risk of prostatic cancer. Again, the hazard ratio, as you see there, is quite low, but nonetheless, there is. So that should be bladder cancer, not prostate cancer. And the FDA have, in the case of pioglitazone, have issued warnings about that. But as you can see, often the challenge with these cancer risks is, you're relying on epidemiological studies, so it's difficult to know exactly how robust those risks are. So if we look at pioglitazone, what you see is that one of the challenges is weight gain. It's commonly edema. The challenge is you have patients who are overweight, and therefore giving them agents which potentially increase their weight further is often a difficult sell. And we know there is a risk of osteoporosis in ladies. Many of you will be aware that there was a great concern with TZDs around cardiovascular risk. I think the perceived wisdom now is that there is not an increased risk of cardiovascular outcomes or adverse cardiovascular outcomes of pioglitazone, but that you would not use them in patients with evidence of heart failure. So again, I think the key take-home message here is that these agents can be considered, and I'll come on the ASLD guidance in my next slide, but you need to weigh it up on a patient-by-patient basis. It's an informed discussion talking about what the potential benefits might be versus the risks. So if we look at some of the other therapies that you may be considering, metformin, there's very good reasons why it might be effective. However, the studies don't really demonstrate an independent effect of metformin. So I think my practice and others is you use it in patients who have got diabetes, and certainly that's a must, but you wouldn't use it for NASH specifically. So if they don't have diabetes, I don't use metformin. Similarly, GLP-1s, the glucagon-like peptide-1 analogs, great for diabetes, licensed for diabetes, licensed for weight loss. But whether they have a specific licensed indication for NASH, the answer to that, is awaiting further large-scale clinical trials. But as you'll see, the AGA SLD guidance does recommend the use of pioglitazone, notably at this point in time reserved in those patients that have a liver biopsy that shows NASH. You'll notice that the slight difference is that you can use pio in those patients with and without type 2 diabetes, whereas for vitamin E, it's reserved for those patients without diabetes. And that's really based on the previous data rather than a specific hypothesis that vitamin E wouldn't, for example, work in those with diabetes. The focus of this webinar is pharmacotherapy, but I think it's really important to establish that the right treatment for patients is to try and help them achieve weight loss. We all know how difficult it is to do that, and it's about trying to create a constructive environment in which they can make the dietary changes in particular, but also changes in physical activity. And depending on where you are, you have varying access to weight loss medications. And of course, bariatric surgery is a well-known treatment at reducing the excess weight in these patients. So we also know that the commonest cause of death in patients with fatty liver disease is vascular disease. The second commonest cause of death is non-liver cancer. So it's really important that we practice holistic medicine, and it's getting on top of their glycemic control, their blood pressure, their lipid profile, because if you don't get those right and you focus on the liver, you're missing the commonest cause of death and morbidity in these patients. And one thing that's worth emphasizing here is that one of the questions I often get from primary care doctors is, I've got a patient with abnormal liver bloods, they're on a statin, should I stop the statin? And the answer is 95% of the time, no, you do not. Statins increase survival in patients with NASH, and only if you're seeing a true drug-induced liver injury with ALTs rising to the hundreds, after the starting of a statin, should you be considering that. So really, once you've got these two things in place, the weight loss and the diabetes, should you be considering liver-directed treatment? As you are sure are all aware, there's been a huge amount of energy and effort from academic investigators and now the industry sector looking at different pharmacotherapies. So this is just an example really of some of the current agents that are being tested in phase 2 and phase 3, and there's many, many more. And I think you can try and break down their action in terms of classes. So you've got drugs here that act on insulin resistance or perhaps lipid metabolism. You've got ones that modulate oxidative stress or lipotoxicity. You've got other ones that try and modulate the immune system. You've got others that try and modulate cell death, such as apoptosis. And then finally, you have those agents that target liver fibrosis. So in the next slide, you see some examples of agents which have been tested and shown not to be effective in the treatment of fatty liver disease. So those agents are not proceeding forward. In this slide here, highlighted in green, is picking out those studies which have gone through to phase 3, which is the obviously the final stage of testing, and I'll touch on the pathway that these new therapies need to go through. So if we just look at some of the treatments in phase 2, I think we've picked out some ones which we think look particularly exciting. I think we've got inhibitors of galectin-3, which potentially have important effects on portal hypertension. There's a suite of FGF analogs, whether it be FGF21 or FGF19, and these have been shown to have potent effects on lipid metabolism, and that's commonly measured in trials looking at MRI proton density fat fraction. We've got GLP-1 analogs such as semaglutide. So this is a class of drugs which, again, I'm sure many of you are familiar with in the setting of type 2 diabetes. We've also got increasing numbers of combinations where you combine GLP-1s with other gut hormones, including glucagon analogs as well as GIP. So there's a lot coming in the pipeline. So just one point really before we go into the phase 3 trials is to say, well, what are the endpoints when we get to phase 3? And I think the good news is that there has been an alignment here. So you have a very clear standardized pathway. So the principle here is that you have a histology endpoint, which is commonly at 12 to 18 months. And then you have a continuation phase, a sort of phase 4 extension, which is based on hard clinical endpoints. The things that you can see on the slide at the moment are the histological endpoints, which are commonly at 12 to 18 months. And depending on the drug and the mode of action, you would choose one or both of those as your primary endpoint. And if the drug hits that primary endpoint, then the drug gets provisional approval or provisional licensing, so it can be marketed on the proviso that it carries on in the phase 4 extension in a randomized controlled trial where you're looking to see if there's a reduction in hard clinical endpoints such as survival, liver decompensation, development of cirrhosis and the like. So really hard clinical endpoints. So the NASH resolution, as it says, so this is the pathologist saying that this patient no longer has steatohepatitis, which is defined as the lack of any hepatocyte ballooning and minimal lobular inflammation with no worsening of liver fibrosis. Or the other one you can take is a one-stage improvement in liver fibrosis with no worsening in NASH. So let's look at some of the agents in phase 3, an increasing number of these. So just highlighted at the bottom is the point I made. You have the interim analysis of histology, which gives you in the US, the Subpart H conditional approval, pending a final approval at the end of the clinical endpoint study. So what you notice here is that the numbers of patients needed are huge, and the numbers really are determined ultimately by the power calculations on the clinical endpoints. They're overpowered, if you like, for the histology because they're powered on the final endpoint study outcomes. So you've got Cenicriviroc, which I'll talk about in a little bit, which is an antagonist of CCR2, CCR5. You've got a range of different pathways, FXR agonists, PPAR alpha delta, thyroid hormone receptor beta agonists, and then more recently Aramchol as an SCB1 inhibitor. And I'll go through those in a little bit more detail now, just to give you a flavor for them. And you see here that they range from 12 to 18 months in terms of duration. So Cenicriviroc, so this is the principle here, and again, this is underpinned by fairly robust preclinical data in mouse models. So the principle here is that if you block CCR2 and CCR5, you can do two things. One is you block the ingress of inflammatory effector cells, which are contributing to the liver injury, and also you potentially block the stellate cell activation process, so you reduce fibrosis. So potentially an effect on inflammation and also fibrosis. So the phase 2 clinical trial was powered essentially on its effect on inflammation. And what you can see is that there was no effect statistically, in that the reduction in liver injury was not statistically different between patients receiving active drug and those receiving placebo. So you can see the blue there is Cenicriviroc. If you look at liver fibrosis, so this is, notice not a one-stage reduction, but a two-stage reduction. You see not quite reaching significance, but perhaps a sense that something is going on. So when they've done subgroup analyses, what they see is that if you take those patients who had a one-stage improvement in fibrosis and then follow those patients for the 2-year duration, a greater proportion receiving Cenicriviroc sustained that. So suggesting that perhaps Cenicriviroc is able to maintain an improvement in liver fibrosis. And again, we know that fibrosis is the key determinant in clinical outcomes in patients with fatty liver disease, and therefore any drug which has a sustained effect on fibrosis is likely to result in clinical improvements. So again, it's important that we keep a close eye on safety. What do we know about safety? Well, the good news with Cenicriviroc is that there really is not a huge amount with respect to concern, so there's no difference in adverse events versus placebo. Most of the adverse events were mild to moderate, and there were no significant drug-related events or deaths, so all pretty reassuring. What about elafibranor? So again, this is an agent which blocks PPAR alpha, which, as you can see here, has an important role in fatty acid oxidation, also inflammation, whereas PPAR delta seems to be more important also in elements of fibrosis, as well as also glucose homeostasis. So what we see here in the phase 2 clinical trial, which is what has driven the phase 3 clinical trial, is that if you perhaps focus on the panel on the right, this was a 12-month study. And what you can see is that patients receiving the higher dose of elafibranor, the 120 milligram dose, had a statistically significant improvement in liver injury as measured by disappearance of ballooning. So suggesting that with this agent, you can see improvements in liver inflammation, and that's led to them proceeding with a phase 3 clinical trial. So one of the agents which has just reached its interim analysis is Obeticholic acid, and you may well have heard a lot about this agent, partly because it's also now licensed in the treatment of patients with primary biliary cholangitis. Now, what we see here is a fairly complicated diagram, which really captures the very many different ways that FXR could be relevant in the setting of fatty liver. And I think this is one of the challenges with agents, because they almost have so many different actions that it sounds too good to be true. So there are potentially actions here on insulin resistance, beta oxidation, so it enhances the clearance of free fatty acids, also effects on inflammation, also perhaps effects on portal hypertension, and potentially direct action on stellate cells impacting on fibrosis. With that in mind, the phase 2 clinical trial looked in particular at inflammation, which it was significant at improving. But what was interesting was that there was a more profound signal on fibrosis. So when they went through to their phase 3 clinical trial, when they started, they had an either-or primary endpoint, which was either an effect on inflammation or an effect on fibrosis. Now, the interim analysis focused on just under 1,000 patients who had reached this stage in the trial. So the other change that we see in trials is that increasingly trials are focusing on people with moderate to advanced liver fibrosis. And I think the direction of travel will be more towards patients with F3 and F4, i.e. cirrhosis, because I think that's where the greatest unmet need is, and in all likelihood where payers will start with. So these data were presented at the International Liver Congress recently and published in The Lancet. And what you'll see is that the primary endpoint of liver fibrosis was met here with the OCA 25 milligram dose. There was almost a doubling in patients who had an improvement in fibrosis by one stage compared to those patients on placebo. Interestingly, if you look at resolution of NASH using a fairly rigorous read, there was no difference. So the sense that we get is that the predominant signal is fibrosis. There's been some discussion about, if you look at different ways of looking at NASH resolution, there may be an effect, so that remains a possibility, but the clear focus is on the fibrosis. If we look at adverse events, and apologies, this is a slightly busy slide, the thing to focus on is pruritus, and we know that with FXRs, you can get problems with itch, and we see that here. So, you'll see that a substantial proportion of patients receiving the higher dose of OCA develop pruritus. The other thing to point out is the elevation in LDL cholesterol, which is a predictable consequence of treatment with FXR agonists. Many of these patients will receive statin therapy. So, one of the open questions is whether that statin therapy will ameliorate the risk that the elevation in LDL cholesterol from FXR could bring. So then the final study I wanted to touch on was this one here with Resmetirom. So this is the thyroid hormone receptor beta agonist. So the specific focus on the beta agonism gives you this beneficial effect on lipid metabolism, as well as also carbohydrate metabolism. And the recent data that have been presented and then published in The Lancet show a fairly potent reduction in the amount of fat inside the liver from baseline. So you see a 33% relative change compared to placebo. Now, you might say, well, that's great, but patients don't die from fat inside the liver. They die from the development of injury and scarring. Well, there's increasing data now which suggests that if you are seeing a substantial reduction in the reduction in fat inside the liver, then that is quite likely to correlate with improvements in liver histology. So, for example, once you're seeing a 30% reduction in fat, there's quite a strong correlation or a strong suggestion that that's going to predict improvements in liver histology. So that's one of the reasons why that's being used. It also has the advantage of being a little bit more objective. You're not relying on ALT, and in a short-term study, liver biopsies are sometimes problematic. So hopefully you can see that there's a whole exciting range of different therapies being trialed. It's exciting to see drugs hitting provisional endpoints in phase 3. Now, the question, I suppose, comes is, what is the optimal strategy to treating patients with NASH? Now, there's two ways you can look at this. You can take the pragmatic view, which is if it works, that's great. Or you could say, well, actually, if I was to align things in a structured order, how would I do that? Well, as we've touched on earlier on, I think the first thing is getting the behavioral interventions right, making sure you're managing the vascular risk. I think then in terms of agents, my belief is that for patients with NASH, F2 and F3 in particular, you really want a strong metabolically acting drug which targets their weight, targets their metabolic risks, because we know that there you're getting a dual benefit. You're targeting not just the effect on the liver, but you're also targeting, one of the commonest causes of death. Then I would see the addition of specific anti-inflammatory agents, because undeniably there'll be patients in whom metabolic treatments alone are not sufficient. And then you've got the treatment of fibrosis. So in some patients, I think acting on the metabolism or inflammation will reduce the injury, and in turn, you get a remodeling of liver fibrosis. But we know that in some patients that might not happen. So I think in those patients, I see that we'll be thinking of a pulsed therapy with directly acting antifibrotics. So you might use it for 6 months or 12 months, whereas I think the metabolic and inflammatory treatments are probably likely to be longer term treatment, maybe even lifelong, whereas you might be pulsing in with antifibrotics for 6 or 12 months. You'll remember one of these questions that came up right at the beginning. So the poll is open. I don't know if you can all see this, but 85% answered that Cenicriviroc is the CCR25 inhibitor. That's correct. 8% said OCA, 6% said unsure, 2% said elafibranor. So elafibranor, remember, is the PPAR alpha, PPAR delta. So if we go to the next question, so which of the following emerging NASH treatments is an FXR agonist? So if you could please vote on this one. Okay, good. So a quarter of you got that right. So FXR agonist, that is obeticholic acid. Elafibranor, so 16% of you said that. So elafibranor is the PPAR alpha, PPAR delta. 4% said Cenicriviroc. That's the CCR2, CCR5 inhibitor. And none of you said selonsertib. So yes, selonsertib is the MAP kinase inhibitor, which one or two of you have asked questions about, so I can pick that up. So there's a question here about what percentage of patients with NASH progress to cirrhosis. So that's a really good question. And I think it's fair to say we don't have comprehensive data to really analyze that. So what do we know? Well, we know from some of the cohort studies that it takes about 7 to 10 years to go one stage in fibrosis. So remember, within NASH, you've got stages 0, 1, 2, 3, 4. If you're an F3, the suggestion is that it's between 7 and 10 years. Now, there's clearly a lot of variation within there. There's also some bias in the studies, because if you think about it, if you've got a patient with NASH F3 who loses 15 kilos, improves their glycemic control, their FibroScan comes down, you're probably not going to biopsy that patient again. Whereas if somebody gains weight, glycemic control gets worse, you may biopsy them. So what the natural history studies sometimes capture is the natural history of those patients that you're worried about. So it's sometimes difficult to say exactly how many patients with NASH will progress to cirrhosis. But so I think it very much depends on a patient-to-patient situation. At what point do I introduce drug treatment versus exercise and diet? In the UK, as in the US, there are no licensed treatments. So my practice is really much focusing on, behavioral therapy, so diet, exercise, working with a dietitian, considering pharmacotherapies through the weight management team, which includes but not limited to GLP-1 analogs and bariatric surgery, because I think that is really effective. I don't tend to use a lot of pioglitazone. I do discuss it with patients, but I've not found a huge uptake. And I guess my reticence is that, all other drugs have to go through a long outcome-driven pipeline, whereas those two agents haven't gone through that. So I accept there's a place for them, but in my experience, they're not that well received by patients. There's a question here about how many ER visits for fatty liver pain does it take to initiate treatment? That's a good question. I mean, a lot of patients will report, right upper quadrant discomfort. It's not often a major problem, but a lot of them do report it. What's the treatment? Well, the treatment, I'm afraid, is partly reassurance, it's partly weight loss, and partly, analgesics as required, in my experience. How can it be true that vitamin E increases risk of prostatic cancer? Well, I think I made the point that, we're relying on epidemiological data here and, appropriate adjustment for confounding factors. So I'm afraid it's difficult to pinpoint that. I guess you just have to take a measured view as to whether you truly believe that. And when you're speaking to patients is putting into context what that risk actually means. And we know that patients sometimes struggle to, what does a 1% increased risk mean? Do they understand what that means? There's a question right here about mechanism of action for pioglitazone and vitamin E. I think I answered that earlier on in terms of antioxidants and insulin resistance. Am I suggesting that a PCP, so primary care physician, should not prescribe pio until a hepatologist performs a liver biopsy? Well, what I'm saying is that the guidance from the relevant societies is that treatment should not be considered unless they've had a biopsy. So I'm telling you what they suggest. Now, if you ask me that question, well, the answer is that the way I practice is that if patients don't have significant evidence of fibrosis, then I reassure them and they're followed up in the community without a need for specific fatty liver treatment. I look after the patients who I'm concerned about the possibility of fibrosis, so they will have all had a biopsy, because I feel at this point in time, it's still important. I think when you look forward, I think it's unlikely that we're going to require biopsy-proven NASH and fibrosis to use treatments, because that's going to become untenable. But what we need to create is the guidance that reassures payers and primary care physicians as to, how do we define that group non-invasively? So here's a question around a treatment of NAFLD in pediatrics. That's not an area that I'm directly involved in. I think the trials in pediatrics, are going to be challenging. I suspect there will be, an extrapolation of efficacy from adults with evidence of safety in children to use them. Remember, many children won't have developed the fibrosis at that stage. So the other conundrum you have is, given that the endpoints are really focusing on fibrosis, when should you use them in kids? And I guess that's going to be a balancing act, and you may find that you're using drugs for their additional value on weight and glycemic control rather than NASH specifically. There's a question here about what weight loss medication are you advising? I'm not really. I defer that to weight management in my setting, a weight management group, which is commonly diabetologists. You may have more obesity physicians in the US. The drugs that they use, I think, are really, focusing around GLP-1s, but there's gut hormone combinations which may be effective. I think Orlistat, in balance we use it a bit, but it's modestly effective in my experience. Is the impact of GLP drugs likely due to weight loss? I think that's a major mode of action. There's always a debate as to whether there is a weight-independent effect, and I think we don't have the answer to that question, but I think weight loss is certainly a major part of that. There's a question here about selonsertib, so Gilead's MAP kinase inhibitor. That was stopped because of phase 3 trial data showing lack of efficacy histologically for both cirrhosis and F3. What is my opinion on screening for NASH in the general population or high-risk populations? Well, the AGA guidance is that is not recommended. The European advice is that it should be. I think my advice is fairly pragmatic, which is that I think the evidence for screening, we should be evidence driven. In other words, if somebody can demonstrate that it's cost effective to screen either in the population or in a high risk groups known as case finding, then we should use it. That equation changes as you have therapies, of course. So, I don't have a strong view on that. I think at this point in time, we certainly don't recommend that in the UK. The reality is that many of these patients will have abnormal liver blood. And if you have a patient with an abnormal liver blood, then I think you're duty bound to work out why. And once you've worked out it's NAFLD, then you have to work out how severe it is. So in reality, many of these patients are identifiable anyway. So what about patients who are caught early and have NASH but no fibrosis yet? I think in the main, it's monitoring those patients to see, are they developing fibrosis? All the trials are focusing on F2 and F3. I'd be surprised if payers recommend treatment in patients before then. Ultimately the case has to be made that that's a cost-effective intervention, which it hasn't been. Are there factors to predict progression of NASH to F3, F4 fibrosis? There's ongoing work. Interestingly, the presence of hypertension was one that was identified many years ago. I suspect it'd be, the prevalence of metabolic syndrome parameters and weight gain. What are the most useful non-invasive tests for fibrosis? I think we're looking at transient elastography, whether that's FibroScan or acoustic radiofrequency impulse imaging. You also have magnetic resonance elastography, which is going to be probably more trial focused. You've also got serum blood tests. In Europe, we often use ELF, the Enhanced Liver Fibrosis Panel. Of course, you can use algorithms such as FIB4 and NAFLD fibrosis score, but often you tend to use those first and then use something like ELF or FibroScan. Should we be following patients with NAFLD without NASH? And if so, how and how often? In general terms, I think I'm more concerned by patients who've got significant fibrosis. So if they're cirrhotic, I see them every 6 months. If they have advanced fibrosis, I would see them every year. If they've got NASH with F2, probably every 1 to 2 years. The caveat there is if they're a young patient with a very high NAFLD activity score, I'd see them more frequently. But if you've got a 70-year-old with a NASH score of 3 or 4 and F2, in reality, they're probably not going to die from liver disease, so you can see them less frequently. Recommendations for NAFL/NASH screening and treatment in the HIV population. I think the same principles apply, really. Look for fibrosis. What we look for is an algorithm followed by a FibroScan or an ELF blood test. In terms of treatment, that's going to be tricky because we don't have any treatments as yet other than behavioral modification. So what we need to look at with drugs like OCA is, what evidence do we need to suggest that they'll be as effective in HIV, and I suppose specifically about drug-drug interactions. There's a question here about how dependable are FibroScan results. Well, these are all pieces of the jigsaw, okay? So nothing's perfect, including liver biopsy. In general terms, these tests have a better negative predictive value, so a low score is reassuring. A high score often requires confirmation. Here's one about, should statins be stopped if the transaminase levels are in the hundreds? I think it certainly begs the question, could the statins be contributing? So what I'd want to understand is the temporal link. In other words, has the ALT spiked up since they've started on a statin? In which case you need to ask that question. And that kind of comes on to question 16 here about, when do I stop a statin? So I think if it's been in the 30s or 40s and it jumps up to 100, 200, I'd probably ask the question and stop it. Do I expect non-invasive markers to be used as clinical endpoints for NASH/NAFLD? Well, I certainly hope to see that in the future. I think with the OCA trial with OCA, I think it would be interesting to see with the subsequent analyses if they can identify non-invasive markers which capture those patients that are getting a histological response, because that's what we need in clinical practice. So is the FibroScan a good test for monitoring NASH patients' progression and therapy? Good question. We don't really know. I think the phase 3 trials will give us the answer to that question. Is there data that patients with HIV progress faster? I don't think the data are good enough really at this stage. I think there's a suggestion that there may be an additional risk, but we don't really have a good handle on the natural history of those patients. So when would I recommend bariatric surgery in NASH? I think when they have the same indications that anybody else does. So, if they have an elevated BMI and clearly there is national variation as to what payers will pay for, plus the metabolic risks such as NASH, that becomes an indication. There's a question about cirrhosis in children. Yes, children can get cirrhosis. It's pretty rare though, and I think you need to manage it on a case-by-case basis. So what about combinations of therapy such as OCA and PIO and GLP-1? Well, that's a really good question. So, these things, the Atlas trials with Gilead are again looking at combinations. The GLP-1s are going to be combined with FXRs. So, really good question. You can hypothesize, but ultimately we just need to see what the studies show. Do I screen for HCC and cirrhotic NASH? Yes, I do, in the same way. So every 6 months with an ultrasound and an alpha-fetoprotein. So do patients with NASH normal liver blood, but without fibrosis on FibroScan need treatment? No, I think they need treatment to manage their metabolic risks. In other words, manage their weight, their cholesterol, their hypertension, but I'm not treating their liver specifically. So there's a question here about the PPV, the positive predictive value and negative predictive value of liver elastography for determining NAFL fibrosis staging. We've published papers on this, which I'd direct you towards. I think you'll see that their negative predictive value is generally better. Their PPV is less good. So I think you need to be clear what are you trying to do? Are you trying to not miss patients, or are you trying to be very specific? So depending on what you're trying to do, the cutoffs will vary. There's a question here as to whether or not the activity in NASH is similar to alcoholic liver disease. Well, yes and no. Alcoholic hepatitis is quite different to non-alcoholic liver disease. Clearly, there's an overlap. People can be drinking to excess and also have metabolic risk factors. And I think that's going to be the area that we explore in years to come. There's a question here about, are there any effective treatments for class 4, i.e. liver cirrhosis? Answer, no, not yet, but there are trials ongoing. There's a comment here that I've mentioned that metformin and GLP-1 drugs should not be used for NASH, but is this just for patients who do not have type 2 diabetes? No. The point I'm trying to make is that metformin is indicated if you have type 2 diabetes. But if I have a patient with NASH who does not have type 2 diabetes, then I do not believe the data support its usage specifically to treat NASH. And the same applies for GLP-1. So if I've got a patient with NASH who does not have an indication for the use of GLP-1s ordinarily, then I would not use them. So if they're not diabetic, then I would not use a GLP-1 agent in patients with NASH. And last question, there's a question here about a growth hormone releasing agent being investigated in NAFLD-NASH. Any opinions on this? Well, it sounds very interesting. I mean, there's a huge number of different therapies being tested. So again, ultimately, we'll just need to see what the data look like. A question as to whether it be used in the general population. I think the reality is that these drugs are going to be focused in on that 0.5 to 1% of the population that have got NASH with advanced fibrosis. So in that sense, we're talking about a relatively small percentage of patients. That's still a lot, though. 1% of the US population is what, 2.5 million. So I think we're talking about treating, 1.5 to 2 million people. Thank you for all your questions. Thank you for listening. Have a good day.
Thank you very much, Professor Newsome, and thanks to our listeners for joining in. As a reminder, to hear more about NASH from Clinical Care Options, click on the link in the show notes. Please be sure to check back again for more episodes on important topics.